We just put the interpretation instructions in the on screen now, so people can check. Oh, there's Madagascar. We just put the instructions for interpretation on screen, so people can change languages. And yeah, if you want to go ahead and start, and then Juliet or anyone that needs to speak will promote them to panelists. You're smiling, Fatim. We'll fix it. Don't worry.
So let me know how to proceed. If you want to put my presentation up. Thanks. Okay. Bon dia, bonjour, good morning, everyone. My name is Fatim Jallo, and welcome to this briefing on our peer-to-peer learning initiative that we are actually kicking off. This is the first briefing session for this peer-to-peer learning, and congratulations to all the nominees that were nominated by your Ministry of Health that are present here today. And we're kicking this off with the sample transport network peer learning, which all of you will be traveling to Zimbabwe to see how Zimbabwe runs its integrated sample transport. So just to give a bit of context, this initiative, which we're embarking on, is Stellar 2.0. And I know a number of you do have Stellar support from CHAI, ASLM, or APHL in your countries to strengthen lab systems. And we all know that Stellar is supporting 23 countries in the African region. And we actually started Stellar to provide support to countries in 2021, especially countries that had high Global Fund investments in diagnostics, but were not meeting the WHO testing targets at the time. But of course, Stellar evolved together with the COVID being deemed a public health emergency. And then we pivoted and started supporting countries to strengthen their integrated lab systems core capability, but also establishing capacity for wastewater-based surveillance. So then in November 2023, we then expanded and added new countries, but we're also supporting countries that want to scale up their investments in wastewater. So recently, we got approval to move Stellar to a new level, which includes a multi-country peer learning model, which aims to institutionalize proven best practices and innovative solutions for integrated lab systems. So this is basically just building up on Stellar investment. And now, instead of using external TA, we're then proposing to actually use countries in the region that are actually doing or implementing the different innovations and are actually achieving very good results, to then bring other countries to then see how they're doing it and see how they can then go back to their countries and adapt. It's not necessarily that we're going to these countries to copy and paste in our countries. Country contexts are different, but we will get ideas from them. We will discuss, we will establish collaborations, we will learn from each other and then see how we can implement in our respective countries. Next slide. So this slide just shows you the overarching Project Stellar results and successes. Like I said, we started off looking at COVID-19 testing, but then we had to shift and started supporting policy and governance, decentralization of integrated testing, also enhancing testing quality, looking at integrated data systems, and also surveillance, and also several other lab systems support. So this slide just basically shows the successes that we have realized in the different areas with Project Stellar. And I'm not going into details, but we will share this presentation with you all to look into the details of the successes. Next slide, please. So why are we embarking on this? As you all know, and a majority of you, maybe in the past, we're not really closely involved with Global Fund grants because we're lab directorates. It was the HIV, the TB, the malaria program. We were not maybe directly involved. But then we have seen a shift if you look at this figure, you will see that in GC6, which is the cycle, the allocation cycle that we just completed, where we also had lab systems modules, we had 108 million invested in lab systems, not the products, not the equipment. I mean, for the majority, or not the reagents or the consumable, but just the lab systems interventions, which include, let's say, the specimen transport, the lab information systems, governance, quality management systems, supply chain, and also network optimization, or DNO, we call it, or DNA. So we see that from GC6, there was 108. And then in C19, there was an unprecedented increase in investment by the Global Fund in the countries. So about 300 million, which is 3 times as much as was invested in GC6. And then in the current cycle, we have 124 million invested. And the table on the right, on my right, basically shows you the breakdown from GC6 to C19 to GC7. And we see that in GC6, we had 20 million for sample transport. But then there was a huge increase to 32 million just for the C19 RM. And this kind of like was stable also, the investments that countries are making on sample transport in GC7. And this makes sense because sample transport does not stop. Whether it was COVID or in emergencies, we had to establish integrated systems that are resilient enough to be able to take up COVID, but any other new epidemic or pandemic that came up in the country. Like in some countries, they had Ebola, they had to use the same sample transport. In some countries, cholera hit, and they had to use the same sample transport to transport the sample. And we have to continue maintaining the system in GC7. So here we see in sample transport, we have 32 million in C19, and we have 27 million in GC7 in some of your countries. And some of you already that are here today have these investments in sample transport in your Global Fund grants. I am sure most of you here already know about that, are working on it, but are having challenges. So this is why we brought you together to see how can we push implementation. And most importantly, what we need to do is that we need to make sure we use the C19 money. December 2025, the C19 money needs to be spent. Let us try to spend all the C19 money up to December 2025 and then shift to the GC7 money to continue our implementation. So our priority now is how can we ramp up absorption of funds, implementation of activities in sample transport and referral network. So I'm just going to concentrate on that because this is what we're all here for, right? So it's about going back, going to Zimbabwe, learning from Zimbabwe, going back to your countries and implementing. So if you are here today, it's because you are involved in implementation of specimen referral and transport system. If you are not, then if you're here and you are not, good, let us listen, but let us make sure that we support the implementation of the sample referral networks, improve turnaround times, and establish KPIs. Next. So like I said, we're ensuring sustainability, transferring knowledge using a multi-country peer learning. So here today, we're going to talk about sample transport. And like I said, these are countries that have investments in C19 and are all and GC7, but are also considered as Global Fund lab. We call you the lab cohort countries, tier 1 or tier 2 countries, because you have significant investment in lab systems. You have selected or are reporting on work plan tracking measures. So far, we have not imposed an indicator for sample transport, but some of you do have work plan tracking measures that you will be reporting on. And for this project, we will be introducing, and you'll be hearing from the coordinator of this initiative, the Eastern Central Southern Africa Health Community, and you will be hearing from them. Most of you have worked with them, most of you have not, but you're going to hear from them and hear how and what they will be doing to support this initiative. Next slide. So this is the list of the different knowledge transfer areas. And here we're talking about the integrated sample referral. And your mentor country is Zimbabwe. You are all going to go to Zimbabwe. We're also going to have an opportunity to establish a community of practice where we will support Zimbabwe. Excel Zimbabwe will set this up so that you could continue the communication with Zimbabwe before, after, and during the training. So here are the countries. So you're going to be divided into 2 groups. We make sure that not more than 4 countries would go to Zimbabwe at one time. So we're going to have the first group, which is Sierra Leone, Ghana, Kenya, and Nigeria. They will be the first cohort of 3 from each country that will be going to Zimbabwe. And thereafter, the second cohort will be Togo, Madagascar, and Angola. They will be also going to Zimbabwe. And to note, there'll be interpretation, so don't worry. If you speak French, Portuguese, you will go to Zimbabwe with an interpreter. So next slide. So what are we going to measure? So we will take you to Zimbabwe. You will learn from Zimbabwe. You will go back to your country. You will start implementing or accelerating implementation if you have already started. So what we want to see an improvement in your next reporting in SPA 2025. Or 2025, 2024, we want to see an improvement showing that you have really improved your capability on sample transport. We want to see enhanced engagement between the PRs and the lab directors and the programs as well, constant communication to improve service delivery for HIV, TB, malaria, improved response to any pandemic, epidemic that may come for surveillance, see how we can integrate and increase absorption of the funds in sample transport that are in your different funding requests. Also, we want to see you to strengthen the collaboration, not just with Zimbabwe, but with your cohort countries that you will be there with. You will be there with different countries that have similar challenges, and see how you could continue the networking, even ending up with having publications coming out of this initiative. And of course, Zimbabwe will be giving you some assessment, pre and post training. You will also have an opportunity after today to link up with Zimbabwe. Tell them what you're expecting from this training and what you want to see, such that they can also tailor. You're going to hear from them in a few minutes, but we leave you to Zimbabwe as well to continue the communication, and we'll just be on the sidelines. Next. So I'm going to just stop. I'm just going to stop there. But this is just an example of an initiative that we did with Gambia. They went to Uganda and Kenya to also look at their sample referral, but also their lab information system. So we have done this before, and we have seen how successful it has happened for a country that did this. So we're expanding this. I think that's the end of my presentation, and I'll hand over to Agrippa from Zimbabwe. Thank you.
Thank you so much, Fatim. And hello to everyone. Kindly confirm if you can hear me.
Yes, we can hear you. Just we'll wait for the comms team to put up your slides.
All right, so I need to share my screen.
If you could increase your volume, that would be good, please.
Agrippa, we have the slides for you. Did you want to share directly? They're on.
Fine.
Yeah.
You can share from there. It's fine.
Yeah. We can keep going, and let us know if there's something you wanted to add. Then you can always take over and share. But we have the slides you sent us.
That's a perfect arrangement.
Perfect.
Kindly go ahead and share.
Yeah.
Okay, so I think we can go back one step. Yeah, okay. We start from there. So thank you so much, Fatim, for giving us this opportunity. Thank you very much, everyone, for also granting us this opportunity. On behalf of the Ministry of Health and Childcare in Zimbabwe, we're actually grateful to have been chosen as one of the leading countries in terms of specimen transportation. This is a program which we started, and to us it was just implementation, and little did we know that it will have this kind of impact. Nevertheless, we are actually happy to share our experiences We are also happy to also mentor our colleague countries and make sure that they also get to the same level as us, or even surpass what we are doing. And we'll also be happy to learn from them when I mean as they implement, or as you guys implement. I don't want to waste much more time other than to walk you through the business of the day. As a way of starting off, I would just want to give you a background of our system, what has happened up to where we are. If we move 2 steps back, 10 years back, or maybe probably 15 years back, we had challenges around specimen movement and results movement. Initially, if we look at our disease patterns, the only specimens which were moving in our system, there were water samples, and at times would have RPR samples, and at times very few FBC samples. Also sputum samples here and there, but the volumes were not that much. And we're using ambulances or any vehicles or EHTs that would visit facilities. But as the disease patterns then begin to change, we also begin to see increased volumes in specimens that would need testing. And we had several fragmented transportation systems, but we had 2-3 things that were coming out of that thing. Some samples were thrown away because they would have overstayed. Some they would take more than a day or 2 or 3 to get to the lab, and when they would get there, their quality would not be good enough. For some years, we would have results. So there were various things that were happening to these samples. We then came together as a ministry to then say, what do we want to do? They came in EID samples. We then contracted a private courier, which was FedEx at that time, around 2013, 14, 15, thereabout. Yes, it was working, but you find that all the other samples, they didn't have room to also get transported along that. Then 2018, we then sat down and came up with a full specimen transportation framework, which would cater for all samples. And we used the viral load, we used EID, we used the TB as proxy tests for the design of the system. And there we are. We came up with our framework with about 340 clusters, needing 280 motorbikes, also needing 8 provincial vehicles at that time. And it's a hub and spoke model with a provincial approach where we have riders who are based at a district hospital laboratory. They would go around to clinics within their catchment, pick up samples from there, bring them to the district lab. And for those samples that can be tested at that district lab, they will be tested. And the next time that the rider is going back to the same facilities, they will take the results back. For those specimens that could not be tested at that district lab, they would be referred to the provincial testing lab, and we'll be using the provincial vehicle that I've talked about. So basically, that's the framework that we are using as Zimbabwe. And for the size of the country, we have over 2,000 facilities, and we have 280 motorbikes that are servicing those over 2,000 facilities that we're talking about. And these ones we are referring to primary or basic health facilities up to the tertiary. And how then have we done it? We've having developed our framework, and this was a multi-stakeholder approach. in developing this framework. And we've then gone out to the funders to then say, this is what we have as a ministry, and we want to implement this. These are the resources. We have the institutions, we have everything, but we need resources or support in ABC areas. That's so the ministry then partnering with BRTI, who is a private voluntary organization in Zimbabwe. And we also then partnered with the Global Fund as well as PEPFAR to come up with the implementation or operationalization of the system. So what we've then done is BRTI and the ministry, we are partnering or we are collaborating in the implementation, whilst funds are coming through from the Global Fund as well as PEPFAR. And in the design of the framework, we've put in a lot of we've got a lot of systems that we've worked with, and we've also included the DNO, the Diagnostic Network Optimization, and like I've indicated already, it's the hub and spoke model, and fleet operations and management, also like tracking systems. We've got electronic systems, remote fuel, and also route tracking. We have all these in place. Contracted service and maintenance, a strict fuel management system, GPS tracking. Then we also have electronic data collection when the riders do go out. What have we then seen from this whole system that we have then designed? Our turnaround time has significantly improved. It has dropped from over 2 months to around about 5 days, but on average, we're looking at about 11 to 14 days in terms of turnaround time. And basically, the management of our system, like I've said, all our riders are based at the district lab. You find that oversight and management of those riders is done by the lab manager on site. And we also then have our provincial IST coordinators. They are also overseeing the other aspects of the program alongside the lab manager that I've talked about, to make sure that fuel is available, to make sure that servicing and maintenance of or repair of the motorbikes is done on time, making sure that all our riders are properly dressed and have adequate riders gear. So basically, that's a brief overview of the Zimbabwean system there. And if you look at the diagrams there, top left there, that's where the rider is, or the riders start at the lab. There's a lab manager there and the riders, and that's our triple packaging there. We also have our rider there, moving around, picking up the specimens, and eventually going back to the lab. So that's the daily life of a rider in pictures to the right. Next slide. What then are we going to be doing, having shared this background? When we got this opportunity to then say, can you also mentor other countries in specimen transportation? What came into mind? How do we want to execute this this task? So basically, we've designed a program which will execute over a 2-week period, and we'll divide the peer learning into 2 phases, and I'll expand to then say what is composed, or what are the components of the 2 phases. The first one, or the first week, we have what we're calling a provincial field visit to provide a review, the implementation of the systems in Zimbabwe. Then week 2, we'll then we have a review of what is happening, the policies around integrated specimen transportation, the operationalization, then also work plan development for the mentee countries. So I'll then look deeper into what, or expand further into what is involved in the 2 weeks. Next slide. Right. So the first week, when the first week, we are saying we'll have field visits, but we need to then also understand exactly what is going to happen. What is going to happen. So basically, the first thing is day 1 of week 1, we'll sit down with the mentee countries. Then we get to understand exactly what is happening in their context. What is it that they're doing? What is it that they're expecting? So that we also get an understanding and make sure that we assist them in the proper way. So day 1 is more of an interactive or physical interactive session, and we get to understand what's happening around these guys, right? Then after that interaction, we go on to day 2, where we'll be traveling to a provincial setting. In that, we will go for 3 days. Tuesday, Wednesday, Thursday, and Friday, we are back in the capital. What will we be doing? This is a situation where we are going to appreciate the processes right from the primary health level, where we are picking up the samples, to the district lab, where the riders are taking the samples to. Then we also appreciate the referral pattern from the district lab up to the provincial lab. Then at least we have a practical feel of what is happening in terms of process flow, right from the clinic to the district lab to the referral provincial lab. Then we are back in the capital. At least we have that practical understanding of our system. Next slide. Then week 2, this is more for conferencing, where we then get down to business in terms of then understanding how are we managing our fleet? How are we managing the project in the first place? The collaborations, the ownership, the governance and structure, as well as the ownership. This is one area that I would want to understand. Then program management in terms of registration of infrastructure, the fueling, the service and maintenance, personal protective equipment, that is the rider's gear, and all the related equipment that is used in the program. Then program oversight. How do we make sure that the program is functional at the lowest level up to the national level? Then, of course, we've got indicators in terms of monitoring and evaluation. How are we doing it, right? Then we give that whole overview. Then from there, we then expect the mentee countries to then develop some work plans, which we can then review from this end. And by the time we finish day 5 of week 2, we expect our mentee countries to have work plans that they will take back to their countries and then try to implement. And our understanding is we've got different country contexts. We're at different levels of operations. And as such, we're not going to then come up with a straitjacket work plan. Each country will come up with their work plans, which speak to the levels at which they are, and then they go and implement. And from there, we're also looking forward to then probably keep up the communication, continue to follow up with the mentee countries, and find out if there are any challenges that they're still facing, or if they've got any challenges or areas that they need further support on, and we'll keep up that pace and provide the necessary support. And I also hope, if need be, we could actually visit these mentee countries and have an in-country appreciation, or also get to understand the context on the ground. But I think that's for the future. But for this particular collaboration, this is the way we are seeing it, or we are thinking as a country. And before I go on to the last two slides, I just want to mention that this one is not on slide, but we have proposed to say for the group 1 cohort, we host that from the 22nd of July to the 2nd of August. I think that's the slot that we've tried to block from our busy schedule to try and accommodate cohort 1. Then cohort 2, we've looked at our calendar, and the only permissible date is around the 20th of August to early September. That's the next date that we can actually accommodate the second cohort. And just to then complete this presentation, there are some 1 or 2 video clips that I would want to play from the work that we're doing around integrated specimen transportation. Over the past 3 weeks, we've had an awareness. We've gone on to an awareness drive, courtesy of communications department from UNDP, to try and make sure that our program, the country is aware of the work that we are doing. And I think the following clip or 2, I think in the interest of time, maybe we just play 1 clip for us to then understand what we've done in the past 3 weeks. And I believe this presentation will be shared, and we'll also then have time to play all the 3 clips and appreciate the work that is happening in the country. So I think go on to the next slide and play that clip there. I can't hear it. Probably maybe the others who could be hearing it.
No, I think the sound is muted.
Maybe our comms team can help mute the sound.
Zeoda and Tim, can you check on the sound system for the video?
Yes, it seems that we're not able to stream the sound from the PowerPoint presentation just yet, but what we can do, we can share this link along with the presentation and recording of the session after this session.
After the
Okay.
motorbike riders under the integrated space
Oh, yeah, there is a sound.
program. Samples can now be delivered quickly and efficiently.
Meant to government and its partners in the health sector has introduced the investment transport system meant to ensure efficient delivery of critical samples, leading to quicker diagnosis.
Remote villages in Zimbabwe once faced a heartbreaking reality. Essential healthcare services, particularly short tests for HIV and TB, were hampered by slow and unreliable sample transportation. This resulted in agonizing waits for results, hindering treatment and jeopardizing health outcomes for patients. The story has, however, changed after the introduction of a fleet of dedicated motorbike riders under the Integrated Specimen Transport IST program. Samples can now be delivered quickly and efficiently, leading to quicker diagnosis and improved health outcomes for patients.
ndandiri murwere ndari ndakafa kare saka ndiri kufara zvikuru kuburikidza nekuti viral load ikatogwa pari zvino ndiri
Do we
kunzwa
have
kuti utano hwangu
translation?
hwadzokera pakare nengari yekuti maripoti tiri kuawana
Agrippa.
nokurumidza kuburikidza navakomana vari kufamba nemudhudhudhu.
Ini ndiri murwere weTB, ndakarwara kwenguva. Tichatorerwa matesti edu paRoma pachipatara chiri paseri. Matesti ainonoka kuuya. Asiko zvino tangoti ipapo ipapo.
Haiye zvino zvanaka kudhara aitononoka kuuya zvokuti dzimwe nambo unotopedzisira watokushipa.
48-year-old Christmas Changa, one of the 5 riders operating in Goke North District, clocks over 160 kilometers daily, collecting and delivering specimens from the 22 facilities to the chest hospital.
Yatinotevedzera iri kuyanga iri mulebhu mamiya saka on a Monday tinenge tichiuza kuti tichaenda uku.
Director Laboratory Services, the Ministry of Health and Child Care, Dr. Ayuba speaks on the scope of the program.
We now have integrated sample transportation, which covers all the districts. So we were using HIV viral load test, and we have managed to reduce our turnaround time from as more as 3 months to almost 11 to 15 days. And in some instances, at the lower level, the turnaround time is reduced even to a single day because of information systems that we have also deployed with the system.
The IST program being implemented by the Ministry of Health and Child Care together with our partners, the Biomedical Research and Training Institute and UNDP, extends far beyond the Goke North. 280 motorbikes and 8 provincial vehicles have been availed so far under the IST program to ensure timely diagnosis and treatment for HIV, TB, and other illnesses countrywide. Abigail Tembo, ZBC News, Goke.
All right. Thank you very much for that. I think in the interest of time, we'll just play that one. I think the other areas, they were English-based and we could understand. But for those clients there, that's our native language in there. But those clients were just acknowledging that previously for monitoring of their HIV tests as well as TB, they used to take long or never used to get their results. But with the introduction of the specimen transportation program, they no longer have challenges in waiting or getting their results on time. That's what those clients who were interviewed were actually saying. And I think the other sections of the clip, they're in English and could easily be translated into either French or Portuguese. But this is one of the clips that we produced from the interactions that we had or the communications that we actually had over the past 3 weeks. And we're in the process of developing a documentary to showcase the work that is happening in integrated specimen transportation systems in the country. I think I'll end here at this point, such that probably if we have any questions or any areas of clarifications, we can, we'll be happy to respond. On the call, I have my colleague from BRTI, Chiedza Mguni, whom we work hand in glove with in the program. And she will also be happy to answer if we have got any questions that you need to throw to us. Thank you and over.
Thank you so much, Agrippa. Like Agrippa said, you'll have an opportunity to reach out to him before you travel, ask, also inform him maybe what your challenges are and what you're expecting from the training. Regarding your travels, this will be handled by EXA, and I don't know if somebody from EXA is on the call. Just come up and just maybe give a brief of how travels will be organized and the logistics. I see some of my EXA colleagues are here. Andrew, do you want to just come up for a few minutes and just explain? Maybe you can put your camera on, or if you have a presentation to share, let us know.
Okay, thank you, Faten. Apologies, I'm not able to put my camera on, but I'll just speak briefly of the role that EXA will play in this project. First of all, I'd like to indicate that EXA, which is the East Central and Southern Africa Health Community, is an intergovernmental organization established to promote regional collaboration in health. We currently have 9 member states, and we are headquartered in Arusha, Tanzania. Incidentally, we actually celebrate 50 years of our existence. This week, we had the culmination of our Golden Jubilee celebrations. We've been a principal recipient of the Global Fund since around 2015. And one of the main projects that we implement is the one that supports national TB reference laboratories. And this is implemented with Uganda Supranational Reference Lab as the sub-recipient. And we are supporting 21 countries in this regard. But we also have a number of other Global Fund supported projects, such as the COVID-19 response mechanism, which looked at the Global Laboratory Leadership Program, as well as proficiency testing for COVID-19. So we're very pleased to have been contracted by the Global Fund to coordinate and facilitate this peer-to-peer learning. Some of you may be aware that we started with the adaptive leadership training about 2 weeks ago, and it was a great pleasure to meet some of you in Nairobi at that meeting. So with regard to the peer-to-peer learning, we look forward to working with you all, both the mentor countries and the mentee countries. We believe that the major ingredient for success with regard to maintain very effective communication amongst ourselves. So as EXA, we will be responsible for your travel, for your accommodation, and other logistics that are related to the program, both in terms of stay in the countries where you will be going. In this particular case, we are talking about Zimbabwe. So we are at your service. Please feel free to reach out to us, and we hope that we'll implement this without any glitches, or indeed if there are any challenges that occur, we'll be very pleased to respond to them as quickly as possible. That is briefly what I thought I should share.
Thank you so much, Andrew. Thank you so much, Andrew. So for all the participants, EXA has your email addresses, so they will reach out to you to start your travel plans, visas, flight. They will share with you flight options such that you will be in Zimbabwe for the time of your training. So the cohort 1 is July 22nd to August 2nd, as Agrippa said, whilst cohort 1 includes Sierra Leone, Ghana, Kenya, Nigeria, is all Anglophone, whilst cohort 2 will run from August 20 to August 30. That's the 10 days. And cohort 2 includes Togo, Madagascar, and Angola. So it's Francophone as well as, if needed, translation in Portuguese. If Portuguese is not needed and the Angola team speaks French, please let us know as well, such that we will not need translation for Portuguese. But if you need, it will be available as well. But please let EXA know if you could speak French. But the second week will be French as well as Portuguese for Angola. And for that, I will now stop talking and I will open the floor for questions and answer. Over to our comms team. If you have more questions, please put it on the chat and we will answer them. Thanks. Yoda, you're going to read the questions, right?
Yes, I will. So question 1 is to Osborne. Agrippa, from Osborne to Agrippa. Integration of sample transport across disease programs has remained a thorny discussion, resulting in continued siloed transport systems. How did Zimbabwe manage this difficult conversation and buy-in in across programs?
Thank you very much, Osborne. This is a very sensitive area and you've put it very well. It's not been an easy road for us. Initially, you would find that specimen transportation, each program would want a good share of control in as far as movement of specimens is concerned. So no one is ready to give away what they're holding on to. So we've got people in the HIV program, people in the TB program, malaria program, and so forth. So our approach in this discussion was to put everyone on the table. During the design of the IST framework, it was a multi-stakeholder approach that we used. TB gurus, they were sitting in the HIV, environmental health, malaria, lab partners, even the funders. We set everyone down to say, yes, we've got an elephant in the room. How do we make sure that we dissect this elephant in a way that everyone gets a share of it in a fair manner? So this discussion, we managed to then break our walls and come into one to then say, we need to be transporting all the specimens. And this is the cost of the siloed transportation that we are having as programs. These are the gaps that we have in unsupported districts, but these are the benefits that we set to get. Probably, for example, say we are moving one TB sample at a cost of maybe $5 per sample, but in the spirit of integration now, where we are saying all the samples can be moved using one bike, maybe that cost drops to about $2 or $1 per sample. And those are cost efficiencies that we were talking about. And all the assurance to then say, the sample will definitely be transported, the confidence in the system. So we had to bring everyone on the table and make sure that we share our vision. And that's how then we got all the buy-in that we have in the program at the moment. And I must say, in our 3-4 years of implementation, we've seen a lot of improvements in the way samples are handled. And we've also seen confidence growing amongst our programs. Of course, during the teething stages, we'd cry baby to say, our samples have not been picked up, our samples are like this, we've got special samples, and we've come in to then demystify and say, let's make use of the system in this way. We've also learned our lessons and improved in areas which we were not doing very well. But I must say, multi-stakeholder engagement is a key to the success in any program, including specimen transportation. Thank you, Ndova.
Thank you. And we have another question to Agrippa from Gaius Matthew. Kindly shed more light on the sample types covered by the network. Thank you. And then there was an answer from Chiedza, but I'll let Fatim and Agrippa to respond to this one if needed.
I think Chiedza can come on and just summarize what she wrote.
Yeah. It's every sample, any sample that needs testing and needs transportation, we're picking on it. Thank you.
And then follow-up question from Omolara. If yes, to the above question, do you have any challenges transporting all specimen types, or is it stress-free? And I think we also got an answer from Chiedza. I'll let colleagues read it, and we'll also share the slide after the session. And in the interest of time, we could probably go to the next slide.
I think go to the next slide. We cannot read it. It's just the translation, maybe. I don't know whether the translation can translate the answers. I don't know if that has been done.
Yes, question 4 from Joshua to Chiedza. Can you speak to the temperature requirements for the different sample types you listed above?
So, Agrippa, you want to come on to answer the temperature requirements and how you control temperature?
Yeah, we actually do what we call rider capacitation, both at national level and also at district level. And we train our riders on issues around simple specimen rejections, then also specimen integrity, quality, and biosafety. So our riders are very well aware of the temperature requirements, and we provide triple packaging and also ice packs to make sure that those specimens which are temperature sensitive, they are also catered for. So our riders know very well which specimens to put in the cold space, those that need normal room temperature, and we've got our carrier boxes which are accommodated the different temperature requirements for the specimens. Thank you, Nova.
Question from
I
Janet.
just want to add, I just want to add, Agrippa, there's also a temperature monitoring device that go in with the samples, and that is also monitored electronically, yes or no?
Sure. We have that the data loggers, they can track temperatures right from right throughout the journey of the rider, and we can actually then look at that to see where we've got challenges and also improve, but we can track the temperatures using that. Thank you.
Thank you. And the question to our panelists from Janet, what is your sustainable plan?
What we've done, if you look at our system, it's purely engraved within the Ministry of Health and Childcare. And what we've simply done is, if we look at the oversight, I indicated that is done by our lab managers at the district hospitals there. So what we only need, if donors or partners or funders were then to say they are pulling out, is just a little bit of funding to make sure that our riders are on board. The infrastructure is already there. For service and maintenance, we also have our own internal government service departments, and fueling is also part of the responsibility that the government would then need to take up. So in any way, the cost was going to be there. And definitely it's actually sustainable, because most of, or almost all the components of the program, they are in line with the way government is currently operating. Thank you.
Thank you. Question 6 from Gituma. Apart from traditional supported samples by partners such as VL, EID, and TB cultures, how are the other samples that require payment modalities done? If there is a scenario there, though not quite sure.
We're not charging for any specimens that we're transporting, and you would find that health services in Zimbabwe, we actually have these specimens and also other tests or other services that are not charged. They are just offered to our public for free. And for specimens, we are not spared. We also have those that collected, and we do not ask for any charges. But as the tests also get complicated, there are some tests which then require pay. But if you look at those type of specimens that then require payment, you find that the patients themselves would actually have been referred to or up the referral system, and that's when they will meet such type of costs for the specimens that are collected. But for the basic primary specimens that are collected at these levels, there are no charges or payments that are actually required for. Thank you.
Following up with the remaining questions, we have 2 more questions, and we'll also group the questions about the cohort meetings in the following slide. Fatim, would you like we cover these 2 questions before we go on to the next slide, or do you want us to go to the next slide directly?
Let's answer all these questions here. I think it should be fine.
Sounds good. Then I will read for translation purposes. Question 7 from Antonio. Congratulations on the presentation. I would like to know if the means used to transport the sample are private or public.
Like I said earlier on, all the infrastructure has been procured for the government by the funders, and these are the motorbikes, and they only operate within the public setting. Thank you.
Question 8, how do you ensure the sustainability of our transport system, especially between the end of one project and the start of another? That was translation from the French.
Yes, there's been already I've talked about the other part of sustainability are in question 5 there. But in terms of one project to another, I think just like any other projects that are running in the different systems or different lab system strengthening activities, there's always proposal development from 1 year to the other. Like for instance, GC7 is running for the next 3 years. We've already put our plans we've already put our proposals and plans for the next 3 years. And when we near the end of GC7, I think 2026, we then also start planning for 2027, 28, and 29. So basically, this is how we are also doing in specimen transportation, and it's uniform across the two funders, whether it's PEPFAR or Global Fund. We always plan for the following year during the current year of operation to avoid any interruptions. And if there are any changes, we already plan for those changes such that coming into the new year, we have very few hiccups. Thank you.
Question number 9 from Dr. Felix Sorbor. Majority of the speakers facilitates without gene expert. They here in Ghana do not have fridges to hold the sample ahead of transportation. How do you manage samples before pickup? Are you transporting daily?
Let me put it this way. We've got defined route schedules. There are two things that we need to balance out: the issue of specimen volumes, then also the use of efficient use of resources. So what we've done is we've come up with route schedules for each district and for each of the primary health facilities that we're talking about. So each clinic knows when the bike is coming. So in our framework for the rural setups, they are visited at least 2 to 3 times per week. That's the minimum. Then for the urban clinics or urban rural health centers, they are visited every day. So the route schedules, they bring about predictability and confidence. They know that the rider will be here on a Monday and on a Wednesday and on a Thursday. That's 3 times per week. And they know the times that the rider is actually coming. So you find that for specimen collection, it's well timed in such that they are within the rider schedules. I'll try to avoid as much as possible specimens which are stored. In looking at the complications that then come with trying to store specimens, like then having fridges, trying to have dark corners, trying to have this and that in place so that specimens are stored very well. But in cases where we've got breakdown, we also communicate and we try to give the facilities or empower the facilities on how to temporarily store specimens in case the rider didn't manage to go to that facility for one reason or the other. But in the normal setup, we don't have specimens that need to be stored for any reason or the other. We just make sure that all those specimens, they are picked up in real time on the same day that they are collected and they get to the lab. Thank you.
Thank you, Agrippa. And the comment to Fatim about the cohort dates. Fatim, over to you.
Thank you, Zioda. So I just wanted to, Agrippa said that cohort 1, they've planning for July 22nd to August 2nd. And the cohort countries, Anglophones, Sierra Leone, Ghana, Kenya, Nigeria. You will be reached out by EXA to plan your travel and all the logistics to Zimbabwe, visas, etc. From August 20 to August 30, the second cohort will also visit Zimbabwe, which is Francophone as well as Lusophone, Togo, Madagascar, and Angola. Let us know, Angola, if you're French speaking and you will not need a translation in Portuguese, or if you do, that's fine, just let us know so that we can plan accordingly. I think because we have translation services ending in 2 minutes, I think what I will request you to do, Agrippa and Chietza, is to maybe establish a WhatsApp chat group with both cohort 1 and 2 in one chat, where they will be asking you questions and communicating before they come to Zimbabwe, during, also after. We only have email addresses, so it will be up to you. It would be really up to Zimbabwe and up to each of the countries to share your phone numbers to set up this WhatsApp group. I think it's always easy to communicate via WhatsApp. Please include me in the WhatsApp groups. I want to know what's going on. So, and also maybe EXA would also want to be included, but also this is all optional. And if Zimbabwe wants, Agrippa and Chepsa wants to do this, and if you do, please share your phone numbers with them when they reach out to you. They will reach out to you if they want to do it. So I think for us, we're going to stop here. So Juliet asked a question, Agrippa and Chepsa, which you should maybe consider. A lot of these countries have issues with establishing contracts with private partners between the Ministry of Health and private sector. So maybe having a presentation during the second week on contracting, maybe somebody from BRTI or somebody from UNDP can talk about just highlights of the contracts and what should be, what should not be on the contract. When you talk about also the KPIs would be a suggestion. All right, so I want to thank each and every one of you for joining. Alex, your phone number, I think it would be best to share it with Agrippa because I don't think he'll keep it here, but he will reach out to all of you by email. He has all email addresses and he will, if he agrees, he will set up the WhatsApp group. That's up to Cheta and Agrippa. So again, thank you all for joining, and we're really looking forward to this peer-to-peer learning, and especially looking forward to you going back to your countries and also implementing, and also to know there's a follow-up after the training if you wish Zimbabwe to come to your country to see how you are implementing or just help you maybe navigate some of the bottlenecks. Zimbabwe will also be available to travel to each of your countries upon request, but only for 3 days. If longer than 3 days, then you will have to talk to your country teams. You will have to talk to CCM, see how you can get more support needed in your countries. Yeah. But again, thank you all. Thank you to our presenters. Thank you to EXA. Thank you to Zimbabwe team, Agrippa and Chietza. Thank you to our communication teams. Thank you to our interpreters for this wonderful time, 1 hour together, and have a good evening, good afternoon, and also a good weekend. Thank you all and goodbye.